Ladies and gentlemen, welcome back, and let's now proceed with another TAVI live case transmitted directly from the hub of TIO Global 2026, as we are being hosted by the University Hospital of Bordeaux by our good friends Thomas Modine and Lionel Leroux. There is something uniquely powerful about watching a procedure unfold in real time, the decision-making, the technique, the teamwork. It brings everything we've discussed today into sharp clinical focus. So for anyone joining in now on the panel, we still have Anita Asgar from Chicago, Holger Thiele from Leipzig, Daniel Blackman from Leeds, and Adam Greenbaum from Atlanta, Georgia. And just a reminder, that TIO Global sessions are being chapterized as we move through the program. So if you'd like to catch up on any sessions you may have missed or rewatch previous content, you can do so by selecting the Watch on Demand on prior sessions. So before I give a brief introduction about the case, let me open a poll for our members of the audience. And the poll goes as follows. The treatment of a failing transcatheter heart valve, what should that be? Well, that should be open heart surgery. That's option 1, because ReDo TAVI is a risky procedure. Option B is, well, it should be ReDo TAVI because ReDo TAVI is a low-risk procedure. Option C is, it should be guided by advanced CT imaging to determine the best strategy. And option D is, well, you have no opinion. So while the audience is answering this poll, let's have a look at the case details of our case in Bordeaux that is already ongoing in the hybrid room here. So it is a case where we are facing a patient with a failing transcatheter valve. It's a failing transcatheter evolute valve. It's going to be a procedure related to a 62-year-old person who had a history of Hodgkin's lymphoma and also a first episode of heart failure due to radio-induced valvular cardiomyopathy. Patient has a porcelain aorta, severe AS, severe functional TR, a CTO of the right coronary artery, and is for the rest a preserved ejection fraction. This is the echo. You can appreciate the tricuspid regurgitation. And this is the TAVR procedure that was performed with an Evolut 29 millimeter in 2018. I don't know whether we can get that running, not really. But at the end of the day, we are now 8 years later. The patient is again heavily symptomatic, and there is severe central aortic regurgitation. We have a persistent, severe, and then secondary MR, but also mitral stenosis. There is persistent severe tricuspid regurgitation, and there's also septal hypertrophy. So this is a lot to deal with in one case. This is the CT scan. So there was no valve thrombosis. There was no signal of endocarditis. So this was deemed to be a structural valve deterioration based on with severe central regurgitation. And we'll have a session later on focusing more on structural valve degeneration. So the heart team discussed, well, this is a highly symptomatic patient that requires an intervention, but because I think multiple criteria, this is a patient at very high operative risk. That said, the STS predicted risk of mortality only 2.3%, but deemed to be very high procedural risk. Remember, patient already had a procedure, has a porcelain aorta, and has multivalvular disease. The team has opted for a sequential strategy. So first they did a septal alcohol ablation, and then to do a ReDo TAVR, and then consider treatment of the mitral regurg and mitral stenosis, potentially with a TMVR. So this was the alcohol ablation that was performed a couple of weeks ago. And this is the CT scan in the workup for a ReDo TAVI procedure. So you can appreciate the evolute valve. You can also see the large sinuses. And what we also do is CT-based simulation of revalving procedures. And it's becoming more and more of interest that with these simulation techniques, you can really determine lifetime management of patients who undergo surgical or transcatheter valve implants. So this is a very nice new development development. These simulations allow you to interpret how a valve is seating once it is implanted, but at the same time, it also allows you to interpret the coronary takeoffs and even determine patient prosthesis mismatch. I'm trying to advance these slides. So here is the right coronary ostium. I think there is, it's a relatively wide sinus. Let's go to the left coronary ostia. And it's still more on the coronary ostia. I think it is also, there's also a CTO involved, so I wouldn't mind too much about this. And then the left coronary was deemed to be at risk for a coronary obstruction. Well, not so sure if I interpret these images well. I see quite some space. The VTC ratio is quite nice, but maybe the valve to sinotubular junction, the VT-STJ, is relatively small. If I read properly, it's less than 3 millimeters. So that probably will be an argument to consider leaflet modification in a supraannular functioning evolute valve. So let me see if I can proceed. So this is a high risk of sequestration. So that is why the team is considering to do a unicorn. So far, we have been discussing electrosurgery, the conventional electrosurgeries, whether or not to be balloon assisted, but it's laceration. So with unicorn, the purpose is to implant the valve in the leaflet. So you make a hole in the leaflet and you implant a new valve in the hole within the leaflet. So that is a different approach of leaflet modification. And here they describe how they will use an astato wire, a microcatheter, and then a coronary balloon, and then upsize it with a peripheral balloon. And I think that they eventually also want to do a 14 millimeter balloon to create space. They are considering to do a revalving procedure of a failing evolute with another evolute. So that might be quite interesting and is definitely open for discussion. They again are going to use the Savi wire as their wire that allows them to do continuous hemodynamic monitoring, and they are planning to close the arteriotomy with a percusile. At least that is the procedural planning. So the patient will be under general anesthesia. There will be, again, TEE monitoring. I think that is a wise thing to do because these procedures may be hemodynamically a little bit more unstable. So it's good to have the patient under general anesthesia and also to use TEE monitoring so that you can better follow step by step the procedures that you need to do, the sequential steps that you need to do for the leaflet modification and for the valve implantation. So with that, I think we are ready to see the results of the poll question. So what is the answer of the audience to this question? The treatment of a failing transcatheter heart valve. Should it be open heart surgery? Not necessarily. Should it be ReDo TAVR as a default? Well, almost a quarter of the audience is saying that, but the vast majority is already suggesting to do advanced CT planning and then to determine the best strategy in function of the CT findings. And I think that definitely makes a lot of sense. So with that in mind, maybe a brief comment by Holger. Holger, do you agree with our audience to always rely on CT planning before opting the right or the proper strategy for a patient with a failing transcatheter valve?
Yeah, sure. I think CT is a prerequisite and we really have to do CT imaging before we make any decisions on how to proceed. And as you also presented the case, there is a high risk or there's a possible risk for coronary obstruction. And this is the only or the main information we get from CT. And that's the reason why you have to do a CT before you decide which way to go regarding ReDo surgery or maybe also ReDo TAVR as a valve-in-valve procedure. But for sure, and also in Leipzig, we surely would have chosen to go for a valve-in-valve procedure in this situation.
Okay.
Yeah. Then you are the PI of a prospective registry on failing transcatheter valves. Is CT planning then mandatory for these cases?
Yeah, absolutely, Nicolas. No doubt about that. I think the key with ReDo TAVI, like any TAVI, is planning. But so I think, but the pre-ReDo TAVR CT analysis really has to be very detailed and structured. I think it's also worth remembering you need to get further data as well. Try and get the pre-index TAVI CT if you can, so you understand the native annulus dimensions and anatomy, whether there's landing zone calcification, what the sinuses were originally, whether it's tricuspid or bicuspid. That's going to affect how well you can expand the second TAV. And make sure you understand everything about the index TAV, what the size of it was, the labeled size, what the dimensions are, where the leaflets sit. So I think there's the pre-ReDo TAVI CT is the most fundamental bit of data you need, but you also need to think about those other things as well.
Yeah. All right. So with that, let's go to the hybrid room here in Bordeaux, where I assume we have that same dream team. So Julien, Guillaume, Lionel, and Thomas. Over to you.
Good afternoon, Nicolas. We've been listening to you very carefully. So as you've said, this is a very difficult case. We're not going to discuss the history of this patient again, anything that you don't like to operate on, and even the TAVR case is going to be very challenging. However, I think by a careful analysis of the CT, as you have been and Holger demonstrating, I think there's a step-by-step bailout procedure here that we can do, and we're going to show you how we did it. So we are using a cerebral protection. As a matter of fact, this is a very high risk of emboli patient with a porcelain aorta. And you see there's going to be a lot of material in the aorta itself. The aim is to do a TAVR in TAVR. The biggest risk here is also coronary obstruction, mainly on the left, as suggested by the CT analysis. Look at the huge amount of calcium. This is also why we want to be very careful about cerebral protection. So we have a radial access. We have a femoral access, in which we're going to show you, again, step by step, how to get out from this risk of coronary obstruction by performing a unicorn procedure, which opened the door and secure the TAVR implant itself. This is guided by echo, and you see how the echo is useful here throughout this procedure. Lionel, you want to say anything else?
No, as you can see, it's intravalvular leak on a degenerative evolute. And we can discuss a long time about our choice today to do an evolute in evolute. But today with the FX Plus, we are sure to not add some frame in front of the left coronary ostium, which is at risk of sequestration. And we are pretty sure to have a good commissural alignment. So it was the reason of our choice. But for this, we had to do a modification of the left coronary leaflet, and perhaps unicorn is one of the most powerful and simple way to do it.
So, Nicolas, just to anticipating the question, using an evolute FX Plus in the previous evolute is based on the fact that with these large windows, with the evolute FX Plus, together with the commissural alignment guided by the CT scan analysis, we would be able to perform the same quality of implant as the first time. And adding this unicorn would also resume the risk of coronary obstruction. This is how we made our decision. This is subject to discussion, of course, and we'll be happy to take any question from there. But I think let's focus a bit on this unicorn procedure. And I know that Adam is listening, so if you don't have more further questions, we can proceed.
Okay, you sure Adam is listening?
Yeah.
So we will try to do an unicorn, okay? Stay humble. This can be a very tricky procedure. So here about the setup, you've seen that we're on with 14 Frenchies in the left arterial femoral axis, and we inserted a 90 centimeter AL1, 7 French, in which we introduced 5 French mammary arterial catheter. And so, because we have also the fusion with the CT, we choose this incidence to be perpendicular to the annulus and to put the left coronary leaflet on the right of our screen. And so we were there with the AL1. At this step, we go out of the AL1 with a 1 meter 5 French mammary catheter, and we advance a micro catheter in this. And so we are perfusing it with glucose 5% because we don't want to lose power of electricity when we will do the puncture. So we are coming with an Astato 20, and you can see here the tip of the microcat. I can move it a little bit. So I move the tip of the microcat at the end of the mammary catheter, and I come with the Astato close here to the leaflet, and you see that I'm able to push a little bit. So we want to be in bottom of the leaflet, but also with a direction coming back to the LV and not coming, of course, in outside of the aorta. So what we want to see in TEE is the positioning of our system before perforing the leaflet. And Guillaume on my left will be able to push a little bit to have this good curve.
Yeah.
So you can push a little bit the mammary inside.
Yeah, like this.
Un peu plus, vas-y.
Okay, a little more.
Okay, and you see now we are parallel and targeting the LV, and I think we are in a good position. We can check that with the transvagal echocardiography. So, Julien, what do you think?
Yeah, so we can see the in-phase view of the valve here. So the left coronary cusp is here. The cusp is very immobile, and you are positioned just here. If we put the explain view on, we can see here on the right screen that your catheter is in contact with the leaflet, and you are maybe a little bit, not fully in the middle, but quite.
Okay, so
So
we can
that's
talk a
about
little
it,
bit anterior.
Ideally, little bit posterior, you are.
Yeah, you're doing the unicorn in the middle of the cusp allows to have a homogeneous splitting of the leaflet itself and be sure that you are equally distant from
It's good.
the coronary.
Good position.
So as you can see, we are able to have a small injection, and we see that we are, I think, well positioned.
Yeah.
Tout petit peu. Ouais, parfait.
So what I did is I scratched a bit the distal end of the wire in order to uncoat it. So the conduction of the electro
Is there?
surgery will be
Yeah.
here.
Okay, so we have a good contact, and we are at cut 70. And so if everybody is happy with the location, we will try to cross the leaflet.
Okay.
Everybody's okay?
Yeah.
So
Vamos.
1, 2, 3. Okay, stop. Okay, so now we will come back. No rhythm disturbance. We will come back to the transvagal echocardiography to see if the wire is well located in the LV, which seems to be the case. And we will be able to advance the microcatheter on it, trying to cross. Garde bien la pression.
Yeah.
Trying to cross with microcat the leaflet. Vas-y, rapproche-toi encore.
Yeah.
So we need to have good push.
So Guillaume is pushing, and so that maintains the contact and allows for.
Débranche
And if that would not work, you can always use a balloon, right?
Yes, yes. It will be easier if we can cross with this one, but we're gonna use a balloon anyway.
So probably not a big entrance.
So
Remember, the leaflet
as
was
you're doing,
thicker
this is,
and fixed.
yeah. So what you're showing,
make
what
the
you're
crossing
demonstrating is a modification. Of what we discussed earlier. So there is no Agilus sheet here, but still it's very elegant, and we could definitely appreciate how smooth
Là, on met,
you
on met
were
300.
able to puncture, to cut through that leaflet. Adam, any comments for based on what you've seen?
And Nicolas, we just crossed as you've seen it, okay?
Yeah.
So now we will use a long coronary wire to do an exchange and to be able to come with a balloon now. And for the unicorn, we want to go in LV and to deploy the valve through this hole. So we have to enlarge it.
So everything's gonna be through this leaflet. Remember that the leaflet should not be an obstacle anymore. Once split it's wide open.
Okay.
Should
So as you're doing this, Adam, any comments
wire.
here?
I?
Ok, on va venir avec
Ouais.
le ballon.
Le ballon.
Can you hear me okay?
Yeah, we can hear you.
Okay. No, I think it's a nice demonstration of a telescoping system to help point back towards the LVOT. So with a guide, if your guide doesn't do it by itself, using an IM or a cut pigtail can help. If your microcatheter doesn't cross, using a small 1.5 coronary balloon to make it a little bit, just a tiny hole to get the microcatheter across. Those are all good techniques.
So,
Okay.
Thomas, any information on hemodynamic instability in previous cases, or is this always a smooth procedure where you nearly never have any hemodynamic compromise because of the aortic regurgitation which you induce?
So I mean, so far we didn't really create any laceration of the leaflet itself. You could tell by at this stage still we have a very tiny hole in the middle of the leaflet itself.
Je vais redosiner ça.
But this may probably happen. This could happen as you expected if when we gonna split completely the leaflet, because we're gonna have two cusps in action and the third one is completely open. We in our experience, we haven't seen this yet, but maybe Adam and others and you have done more cases, but this can maybe encountered. I agree with you. We always have to be ready for. So the valve is mounted, for example, the wire is ready. So when you do these cases, I agree with you. You should anticipate this problem and be able to continue quickly. This is an excellent question.
So in the study, we've seen quite a few unicorn procedures in the revalve study, and we've seen one case of of major hemodynamic collapse after balloon inflation, which was a 14 millimeter balloon in a degenerate accurate NEO. So one of the questions is balloon. What's the best balloon size? You can probably get away with a smaller balloon in a porcine pericardial valve like the Evolut than a bovine, maybe. Some people would argue. So it's going to be interesting when we get more data from revalve and other prospective registries of ReDo TAVI. But we've seen one case, as I say, of hemodynamic collapse requiring kind of resuscitation and emergency implantation of the valve. The patient did well, but maybe a 14 might be too big. I don't know what Adam's thoughts are. I know he's more of a proponent of basilica and balloon assisted, but that certainly can happen with unicorn.
But Daniel, I mean, you would agree that anticipating this type of problems, even if it's rare, it's also part of the procedure. Again, valve is ready, the team is ready, so we can exchange it quickly and then get it done.
For sure.
So
and at the same time, because you're planning a self-expanding valve to be implanted in the leaflet, I think it makes sense to come with a bigger balloon. Most cases of unicorn have been performed with a balloon expandable valve as the valve or the platform of choice for the revalving procedure. So I think one of the interesting features of this particular case is that they're going to use a self-expanding valve after they opened up the leaflet. So I think it makes sense to come in with a bigger balloon in that case. Adam, any comments there?
Yeah, I was unclear from the presentation if they plan on taking a 14 to try and
Non, vous
gear
êtes-
the balloon to
ouais, je pense qu'il est
free
pété, hein. C'est ça?
Is that,
Ouais, je
or
pense
do they
que c'est
actually
un but,
plan on deploying the envelope in the leaflet?
Yeah.
So I think we have broken the balloon because there's no augmenting pressure. Okay. So,
Je suis habillé.
tiens, qui te remplace? Ouais, peut-être.
Viens t'habiller.
So what balloon?
Ouais,
What balloon was this,
ouais,
Lionel?
so it was a 2 millimeter of diameter. And now we want to go with a 2.5 or 3. I think we had an effect.
And
So,
it's
but
non-compliant. I
we
assume.
didn't see it because he was broken very fast.
I'll see you later. I'm coming back. Just have to go to.
But you see how stable is the procedure. In fact, the most tricky part is doing the perforation at the beginning, and then it can be very long because of different exchange and increasing the size of the balloon. But if you don't move too much here, you should be stable enough.
Yeah. So are you using non-compliant balloons to do these pre-dills, if you will?
Good question. I think it's better. I'm not sure that what we have on the table. So, vous pouvez me dire si c'est des ballons non compliants ou des ballons normaux?
It's semi-compliant for now.
Half compliance.
Yeah.
So this is a
I would definitely go for
3.0.
a non-compliant here. Yeah, I would go for a non-compliant and then gradually work up. Work my way up
right.
with big.
Yeah, you're right. Absolutely. To be completely honest, we were very happy to do this procedure, but we don't do leaflet modification every day. So you see that how deep we are in the leaflet. So we come back a little bit with a balloon, and we can check.
Okay.
Yeah. Okay. I think we are well located.
Yeah, good.
Yeah, very nice. So, and again, it's broken. Okay. So we can take, I think, a biggest one now.
Yeah.
On a du 4 ou de 3,5. On a plus gros ou pas en corner? Ouais, bah allez. Ah, mais on track au TW? Non? Ok, on va prendre. 4.0 now. And what do you suggest of in terms of size of the last balloon before the valve? 14, 16, 20, 24?
Depends.
I have my
on
idea.
What you're trying to accomplish.
I think if
Is
we...
it your intention to lacerate right to the free edge, or to deploy this evolute in the leaflet? I think that's the key question here. I must say I'm not familiar with the evolute after unicorn, whether it's possible to deploy the evolute in the leaflet or whether really you need to lacerate to the free edge, and that's going to determine your balloon size.
Yeah. Yes, we want to go with the Savvy wire inside the leaflet modification. So perhaps we will use a bigger balloon, like a 20 millimeter one.
Yeah, maybe we want to open completely the leaflet. I put you on the screen. Maybe you can see it. The sizing, the CT once again. So the annular was maybe larger, but the mean diameter of the valve, so the inflow of the valve was around 20.5. So that's okay. So we do the next equation. Yeah.
This time I think
Yeah, it's good.
it's stable. Okay, can go a little bit higher. So we are high
But I think the
pressure.
message here is because you're considering a self-expanding
It's un peu plus haut.
system, I think you need to be more aggressive in terms of ballooning.
Yeah, exactly.
Because the self-expanding device doesn't has the same power as a balloon expandable
Yeah.
sapien valve. So it is more aggressive, and it may also translate into more hemodynamic instability. But as you mentioned, as Thomas mentioned, you guys are ready to go with the valve, so it shouldn't be too long, the hemodynamic compromise.
Yeah, exactly.
Okay. Julien, est-ce que are we in
Are we good? And what is the
when
degree of the regurgitation?
can you add color when we deflate the balloon? It's not massive in this hole. Hein. Dernier coup là.
The regurgitation is not severe in this area.
Yeah, but for now is 4 balloons.
yet.
So not yet.
Not yet.
These are still
Up.
small balloons.
And it's broken again.
Broken again, yeah.
And- yeah, but that is because it's semi-compliant. You need to really do non-compliant
Yeah,
balloons
absolutely.
to really
Yeah.
be successful here. Yeah.
So what we can do now is coming into the LV with the tu peux me tenir ça comme ça. With the catheter. And so we'll be able to. C'est bien. Ah, mais on peut pas. Tu veux bien aspirer là? Bien aspirer là. Ah, mais non. We will be able to come here with a savvy wire this time.
Yeah.
I think there is no risk to lose anything.
Okay. And we have the savvy wire.
And then we'll be able to put bigger balloons. But the hemodynamic is perfectly stable. Can you show us with color if we have something?
Yeah. Yeah.
Tu peux faire sans.
For the moment, the regurgitation is only on the right coronary cusp as at the beginning. And I don't see severe regurgitation around the catheter.
And obviously, the fact that the main mechanism is aortic regurgitation, the issue of the failing valve, is also protective in a way. If it were aortic stenosis, then any additional aortic regurgitation would have a much bigger hemodynamic impact. So I think this is the best scenario if to do this. Yeah, we'll see what happens, because at one point, obviously, we will need to balloon it with a much bigger balloon. But once your savvy wire is in, you have. Go ahead.
Sorry, I just had a quick question. It's Anita. What was, I might have missed it, but what is the evolute that you're planning to put in as your second device? And then
good question.
consider pre-dilating with the bigger balloon just to optimize it anyway, and then.
The first one was a 29. But now we are more. We had the intention to implant 26. So, okay, I don't want to go out, of course. Yes, like this. Okay. Okay, so we're in, good located, well located in LV. We remove everything, and we now want to advance with a 14 millimeter diameter balloon.
So just to clarify for everybody, we don't know if the evolute is strong enough to make the tear to the free end of the leaflet itself in all valves, TAVI valves, different surgical valves. So in this case, they're going to take a balloon that will, I presume, tear to the free end of somewhere on the leaflet, the wire will become centralized now, and then they will
Yeah.
deploy the new evolute, right?
Right.
So that is a modification of Unicorn. That is not traditional Unicorn.
Yeah, exactly.
Yeah,
So
absolutely.
everybody-
You're right. So we come with a 14 millimeter, and we can prepare the 21. So Ozipka 20 just before deploying of the valve. The hemodynamic is still very stable, and with the color in transvagal echocardiography, with just the wire.
So this is what they're going to do, right? A 14 millimeter balloon and then a 21 millimeter balloon. Just if for whatever reason the 14 millimeter balloon would not cross, you can also use a peripheral balloon, a 6, 8, or 10 millimeter peripheral balloon, if that is needed, if that is required. But let's see how this follows.
No. Okay. It will be free.
I just want to be sure.
Yeah, that's what I thought.
We have a small interaction with the valve itself.
Where do you think we are across?
The thing is, it's possible that from the beginning we are here through the. It's possible. What do you think? We were very easily. In the left.
It's pretty common that you get that interaction with the
Oh, okay. Yeah.
isn't it? And it usually doesn't mean you're through the frame. Yeah, it looks like you freed it up now.
No, it's okay. We're free now.
Now it's just getting through the leaflets.
Okay.
Well, and don't forget, we ruptured 3 balloons, and the maximum size was 4 millimeters.
Absolutely.
So
Okay.
I think this may require a peripheral
the wire.
balloon first.
Yeah, maybe.
So I think we are close to go through, but we need some push. So we have no more catheter now.
What kind of balloon is this?
Okay, here we are.
Yeah, true balloon.
It's an Ozipka. No, yeah, Ozipka 14
Okay.
French. Okay, I think it's not too bad. What we can do is coming here with the
pigtail. Yeah, perfect.
And do a short angio like this.
Yeah. Okay.
And we can inflate. Pourquoi ils m'ont pas mis de...
You want to...
Ouais. So this is more important, huh? We see it in echo also. The pressure is decreasing a little bit. Okay. Okay, perfect. Do we have the 20 now?
Yeah.
So you see they're doing this without
Regurgitation is
Yeah, is more massive
the
now.
balloon will stay in place, and now we have a very we have torrential AR.
Yes.
Maybe the wire now is maybe free, so maybe we completely cut the leaflet. Julian, do you have a visualization of this?
I see the wire on the other side of the valve.
Yeah.
So my question is,
the cusp is
completely broken?
Yeah.
Okay, perfect.
Yeah.
So, okay.
Yeah. So that's already a signature, right?
You could try some
lacerate
fast
the-
pacing
the-
now.
Il va falloir un peu de Nord-André pour l'aider.
If you pace fast,
Super.
it will help.
So we ask anesthesiologist to help to keep the pressure.
And we will come also with the valve very shortly.
Okay.
Okay, 20, vas-y.
Do you want to do a rapid pacing maybe?
Non, je pense pas.
That could be elegant. No?
T'as pas besoin. Vas-y. So 20 and then the valve. Okay, completely free. We agree with that. Thank you.
Yeah.
And now
Yeah, not rapid pacing, but if you pace
Now
about
it's-
100, then it'll reduce
No,
the AR.
honestly, the pressure is coming
pressure.
a little bit down.
Okay. Fix.
Yes.
Yeah, it's time for a valve.
Yeah.
Time for a valve.
Yeah, absolutely.
Okay, let's go.
So the valve is ready. We are very happy about that.
Ouais.
Oui, parce que t'es débranché.
It's coming. Transition with the sheet.
So of course we want to have a perfect commercial alignment, but we don't have a lot of time also. So
Yeah.
Okay. At marker.
ça y est, si tu purges, tu l'as. Si tu purges, tu purges. Et tu l'as. Okay,
Let's go.
bring back. So what do you think? I think it's not too bad like
We
this.
have the good hat marker.
Yes. So let's go. Be careful with the sentinel here. Be careful with the valve itself. Thank you. And
All
I
right, come on.
think we're free.
Okay, can you put
Yeah.
the probe a little higher, Julian? Because there is an interaction. We are now in cusp overlap view. Yeah, there is no more.
Ouais, c'est bon, tu fais. Vas-y.
Oh.
So
Okay.
since to the fusion,
We begin to open.
yeah, you can
Lionel?
deliver the valve, yeah. We are able
There
to
is not much
deploy the valve
output,
now.
so you can
Yeah,
go
yeah.
fast.
Open.
Voilà.
Okay. That's what we want to avoid. Sorry.
Oh.
Ok, voilà. Positionne-toi bien avec ton guide. Viens de tes deux mains, là. Voilà, parfait. Point de départ parfait. Yes. That's perfect. Okay. Okay, so let's start. With a small hemodynamics, but it's okay. Okay, we're a little bit down. Vas-y, pousse un peu sur le guide.
Okay.
So very slowly, we want to come back a little bit. Vas-y, encore un peu. Non, on va être trop bas, on va être trop bas. Well, yes, perfect. So I don't think rapid pacing is interesting in this case. Look, oh, sorry.
Ah.
We will have to do rapid pacing at 100.
I'm not sure it's mandatory. Yeah, you think?
Yeah, 140. Yes, pacing on. Wonderful. Pousse bien sur la guide.
Yeah, I push on the
Voilà.
wire.
Ouais, parfait.
Slowly.
Okay, so I was saying that the commissioner alignment seems to be perfect. Okay, good. It will be better.
Okay,
Okay,
stop.
guys. Okay. So we'll do rapid angio,
Okay,
and
may
if
deploy a
we
little
see
bit
the
further.
left coronary,
Deploy a little
we'll be
bit
able
further
to deploy.
because the valve is not open.
Pressure's coming up
Yeah.
now nicely, it looks
Oh.
like.
Yeah, it's coming up. Yeah.
You know, sometimes with
Nice.
these redo TAVI cases, it's nice to even to have a third operator just on the wire so you can get that control. That was obviously a challenge in this case.
I'm not seeing the left main. Yeah,
Allez.
maybe. Yeah, 20.
Non, c'est bon, c'est bon. On était loin.
For me, the left main is very well
Perfect.
perfused.
Yeah, we
Yeah,
see
good.
we see it very well. So the valve is not completely deployed, but I think we see it all. Okay.
Okay.
So the hemodynamic is stabilized, so everything is okay. Is everybody okay with the commissional alignment and the efficacy in terms of perfusion? So what I suggest is just to have a look on the SavvyWire data. So tu peux mettre le
Yeah,
SavvyWire.
sure.
So unfortunately, we didn't have enough time to show you before the deployment of the valve,
Yeah.
but we have the LV in blue and the aorta here in red. So we will have to do an alignment, but you see that there is no more aortic regurgitation characteristics, and the index of regurgitation is here at 0.4, which is not exactly the truth. So what I suggest is to do the final release. What do you think?
Yeah, I agree. Go ahead.
Everybody's agree. So let's start with the final release. I come back with a up.
Maybe pull a little.
I like
bit on
this,
the wire.
You will
Pull more. Okay.
okay to really I already release the
Yeah.
tension.
Yeah. No more
So I,
tension. Yeah.
I
Okay,
completely release the tension. Thank you.
So usually we do this phase very slowly. Here, I think it's very, very stable, but we will do it slowly. We don't want to have any trouble at the end of this procedure. No more leak on transesophageal echocardiography. Very good commissural alignment. And so we will take a balloon 24 to do a post-dilatation. On peut préparer le 24.
You are still attached?
Yeah,
Okay.
but now we are completely free.
Okay, perfect.
We see that the two white pallets in the aorta are very close. So we should have also a good commissural alignment. So we will push the wire in and come back with the... Hop,
Okay.
vas-y, recharge.
Ouais, petite pression.
That's great. I mean, for the
Uh,
post dilatation, I probably wouldn't go bigger than 22 because 22 is the waist of the 26 evolute. So obviously, we've seen the data from the low risk trials suggesting that if you post dilate with a balloon bigger than the waist, there's some risk of maybe that's what happened to this patient. I guess we don't know, but 22 is probably a big enough balloon.
Yeah, sorry, we have it on the table, so we agree that we don't have to push too much. But in terms of muscle mass, Guillaume is not wonderful, so don't worry about that.
Did you check if the patient had
Yeah.
any post dilation in previously when the first valve was implanted?
Yeah.
For the first TAVI procedure.
Yes. Was there
we have a
post-dilation
depth.
and in?
We have a depth, but because it's not noticed in the report, and when we look at the movie, we don't see it. But at this time, it's possible to have done it without any mention in the report. Now, of course, we are mentioning everything. We think that we didn't post-dilate, in fact, and the problem was not the paravalvular leak here, but intravalvular. Now we are doing much more easier post-dilatation.
But the purpose of the post dilatation here is not to correct any paravalvular leak, right? It's just to optimize the expansion of the evolute frame for durability. So to do that, you need a balloon that matches the waist of the evolute and that's not going to go bigger. So a 22 non-compliant balloon would be the best choice. Otherwise, you just risk oversizing the balloon, which you don't need to do.
Yeah, absolutely. The paravalvular leak is not the problem here.
Ok.
On peut récupérer une pression ou pas?
Yes.
Je flush.
Flush que tu sais pas qui te flushera.
Okay.
So
ready for the post-dil?
the hemodynamic is absolutely stable. So here we will have to do rapid pacing.
The 6-ray.
On rezoome un coup.
Yeah. Do you take the wire?
Yeah, I take it for you. So I come a little bit deeper like this. I think it's okay. Stimulation. So rapid pacing on efficient. We can deploy, yes. AV calcified. We could have a rupture here again. Stop stim. Stop stimulation, and we have
On peut simuler
AV
80.
block. So we will have to stim at 80. So it was one possibility we discussed with the patient to have a complete AV block. less than in a native valve, but more than in a surgical valve, of course. So we will have to implant a pacing lead.
Yeah, we can take the
And
balloon
we will, excuse me.
for the isolation and the stimulation.
We will stabilize it, put the pacing lead, and then if we have time, I don't know if we have time, Nicolas, to show if we can go
we are
back.
coming to the end.
Oh, sorry.
I think we're coming to the end of the session, but you did a clear demonstration of a unicorn case and then a modified unicorn case using a revalving procedure of a failing evolute with an evolute valve. I think this was quite spectacular. At the same time, we also saw by TEE that there is no residual aortic regurgitation anymore. So that problem has been solved. I feel that this was a spectacular case, but still done with calm and determination. The execution was perfect. So Lionel and Guillaume and Julien, that was fantastic work. In the meantime, Thomas has also joined me here in the studio. Maybe a final comment by Adam. Adam, your initial thoughts about this live case?
A great job. Well done. Staying calm. Good seeing you guys again. I did think we should just clarify though that in this technique, since you don't know where the split of the leaflet actually is, when the wire centralizes, there is a small but not zero chance that if the tear was eccentric, there still is leaflet in front. There have been cases where there's been failure of this technique because of that. I think people just need to understand. And what we really need is we need to know when the evolute would be strong enough to tear the leaflet just by itself. I think that would be great because then we could deploy some of these intraleaflet. We don't know if it's bovine, if it's porcine, if it's a surgical valve. But it'd be really nice to know if the evolute has enough strength to do the tear itself.
Yeah.
So Adam,
comment, and with the echo, we have maybe more data, and also in the sequestration context, maybe it could be more simple. Yeah. Sorry.
Yeah, and Adam, in my opinion, also a balloon facilitated basilica is also not free from the risk of the same mechanism that you're describing. So I think it is a little bit undefined and undetermined so far what would be the best strategy and what would be the safest strategy. And I also believe that the revalve registry that Dan is running is a very good vehicle to look into prospective data in that regard. So with that, that's all that we have for this particular live case. So thank you again to the fantastic Bordeaux team. And with this, I'd like to close this session. I also thank the panelists for great insights, great input, and also Adam, Grandmaster Adam Greenbaum, for his expertise in helping us through the issues and the science and all the techniques of electrosurgery. We'll now transition into our next session, which shifts our focus to lifetime management. So thank you very much for your attention. Stay tuned for the next session.
See you soon. Bye.